Hello, I'm Bobby Jean Schweitzer. I'm a professor of anesthesiology and critical care and medicine at the University of Chicago, and I'm going to talk about radiological procedures or anesthesia for radiological procedures. And I have no disclosures, and the two modules are radiological procedures, and then we had to squeeze in pregnancy testing somewhere, so we put it here. The first question, which of the following conditions will be acceptable for a patient to undergo an MRI or magnetic resonance imaging? A, body piercings, B, dental fillings, C, an artificial joint, D, a pacemaker, E, a deep brain stimulator. Which is not a concern in the MRI suite? And it's dental fillings. These are not a ferrous material. So increasingly there's pacemakers that are considered to be more MRI compatible than previous pacemakers. So it's not an absolute contraindication, but the MRIs can reset the pacemakers, and so it is still a significant concern, even in the ones who are considered acceptable. So the overarching sort of concerns and specific issues that we want to sort of cover when we're talking about in the radiology suite is different depending on whether one is in the MRI suite or whether one is in a true place where they have X-rays. So for the MRI, the magnet is the sort of key issue that kind of differentiates it from every place else. And we're going to touch on some very specific contraindications and concerns with that. Then there's the radiation-proof rooms, where patients may be isolated from their caregivers because we don't want to expose all the caregivers to radiation. And there's often the need for remote surveillance of patients, either through windows or through video, both in the MRI suites because of the magnet issues and because of the radiation rooms. And for the magnet of the MRI, it's an absolute ban on ferrous objects. So we want to make sure we identify what a ferrous object is. Throughout all of the radiology suites, we may encounter special equipment, but specifically for the MRI and the magnet area, there needs to be some very specific equipment. The other thing that is the reason that we're usually down in radiology giving anesthesia is not so much because of this procedure itself, because these are often diagnostic, though increasingly some of the diagnostic procedures are invasive and painful, and some of the therapeutic endeavors that the radiologists are doing can take some length of time. But usually we're down there because the patients are either healthy and anxious, or they're very, very critically ill patients. And a key thing that usually pertains to every patient anywhere in radiology is that the patient needs to be immobile. And I know we're used to in surgery, thinking that patients should not be moving around, but here it's even more critical because often the imaging has to be started all over again if the patient moves just the slightest amount. So there's different types of diagnostic procedures that can be done. MRI, we've discussed briefly. Patients can undergo computed tomography scans or CT scans. Fluoroscopy, the key thing there is that usually involves moving parts. So the patient may be still and the parts are moving around them, or the patient may be moving as well. Angiography. And anesthesia typically is indicated for claustrophobia, uncooperative patients, or when there's some kind of discomfort that's going to ensue. The patients are not always supine, and this can, increasingly, depending on the position they're in, can increasingly impact how you do anesthesia because of either difficulty managing their airway, difficult access to the patient or the airway. Sometimes they are going to be prone. They may be in lateral decubitus, especially for certain biopsies such as retroperitoneal or vertebral biopsies. So it's important, if you're not familiar with the procedure, to make sure you discuss with the radiologist exactly what position the patient's going to be in. Increasingly, there's either hybrid ORs or there's situations where a patient may need to start out in radiology, go to the operating room, come back to radiology, start out in the operating room and go to radiology. And so there may need to be the transport back and forth if there's not a hybrid room where surgery can be done in the same room that the radiology services can be offered. So these are usually typically, in a lot of the neurosurgical cases, Usually for the planning CT or the imaging part of it, whether it's before or after the surgery, sedation can be adequate, but sometimes it makes more sense just to do the general anesthesia for the entire procedure. But a lot of it depends on how far it is to transport the patient back and forth and how safe it is to transport them under general versus sedation, waking them up and then inducing general later. There may be a need for varying depth of anesthesia very quickly. Some of the part of the procedure is merely the imaging part, where there's no stimulation whatsoever and very minimal need for anesthesia, followed by something that it can be painful, whether it's a biopsy diagnostic procedure or whether it's a therapeutic procedure, and then often followed by the need for the patient to be awake so that there can be a assessment of the patient, either a neurologic exam done or making sure the patient can follow certain commands. So again, these are the kind of things that it's important that one clarifies ahead of time with exactly what the expectations are. With the MRI, the key concept is this whole idea of the magnet or the superconducting electrical current. And this is always on or activated. So even when there's no imaging actually taking place, this machine is running in the background. And it's very expensive and time consuming to shut the machine down and bring it up back online, or the magnet down and bring it up back online. And so therefore it's important that one tries not to do anything that would interfere with that issue. These magnets are incredibly powerful. All you have to do is Google or go on YouTube and you can see, videos or photographs of all kinds of things from, stretchers to wheelchairs to IV poles, stuck into one of these magnets. Sometimes you have to shut down the magnet just to dislodge the magnetic material. But more importantly is if there's a human being, either the patient or a provider, standing between this magnetic material and the magnet, they can be injured or killed even by the force of that device or equipment being pulled into the magnet, because it can be pulled with incredible speed and force. And you can imagine, a heavy anesthesia machine or a heavy stretcher, slamming into somebody. So anytime one is within a certain distance, a certain room where there's a magnet, one must use MRI compatible machines and monitors. So it has to be material that is non-nickel, cobalt, or iron containing. Or if there are those kinds of equipment, they must be bolted to the floor or to the wall. So typically MRI compatible materials are aluminum, titanium, copper, silver, of course, paper, wood, plastic, that sort of thing. So again, we're often required or asked to provide anesthesia for these patients because they must be immobile for some period of time, and that either will be hard for them to do, or they may be very claustrophobic or very anxious or in pain. Or they may be very, very sick patients who need to have, be monitored very closely, especially if they're outside of an ICU environment. Typically, one has a second anesthesia station that is remote and outside of the magnet room, and that has your typical usual equipment that you're very familiar with: an anesthesia machine, cart. That material can be ferrous, but one has to be just very, very careful that one doesn't inadvertently move the patient into the magnet room with incompatible material on board. So, if they're going to induce outside and intubate using a regular pulse oximeter, ECG, etc., then all those monitors that must be removed before going to the room and then replaced with the different monitors. Generally, there's lots of oversight by the radiology services to make sure there's sufficient oxygen, the appropriate equipment, but one does want to check that out to make sure that there's nothing missing from what would be necessary to take care of the patient. The anesthesia can range anywhere from sedation to general anesthesia. Typically, regional anesthesia is not something one would do for an MRI. Supraglottic airways and endotracheal tubes may be indicated depending on the patient condition. Generally, endotracheal tubes and supraglottic airways do not interfere with imaging unless it's specific imaging of the airway where that may be an issue. But generally, for head and neck, cervical spine imaging, the airway device is not an issue. And I think all supraglottic airways are ferrous-free. Endotracheal tubes, if there's an endotracheal tube that is the armored, wired, sort of flexible tube, that would not be compatible in an MRI suite, but all other routine endotracheal tubes are. Again, one is usually remotely monitoring the patient for most of it. While they're doing the actual imaging, you're going to be outside the room. You can be inside the room, of course, intermittently, and when moving the patient in and out. So generally one is either having information from their monitors inside the room transmitted to display stations outside the room, or there's a video camera trained on the monitors in the room, or one's looking at it through a window from outside. We mentioned about the missile injuries that can happen, and this is a perfect example of that. And you can imagine, if a patient's lying there or another caregiver standing there, they could be injured. So many things are incompatible with MRI, including your mobile phone and your watch, and then many things. And if you have, devices, orthopedic devices or pacemakers, you should not be providing anesthesia services. And of course, when your patients do. Another key thing that we don't often think about is the wire reinforced epidural catheters. Some epidural catheters have wires in them, some don't. And pulmonary artery catheters without temperature monitoring are fine, but the ones that have temperature monitoring have a wire in them. That's a problem. If you use incompatible monitors, such as a regular pulse oximeter, that can actually cause burns to the patient from that wires that in those probes heating up. You can also see artifacts on your waveforms due to the radio frequency and magnetic fields. So if you're using invasive monitoring, such as arterial lines, that can be a problem. And the magnet can inside the cone or the dome of the magnet, it can be quite loud. And there have been reported cases of patients suffering hearing loss. So typically they get earplugs before going in. So when your patients are under anesthesia, they can't remember to ask for that or complain that it's too loud. So usually I find that our radiology technicians are quite good about looking out for those kinds of things, but it helps for you to pay attention as well. So a standard pulse oximeter cannot be used. There's a risk of burns. A standard ECG monitoring cannot be used. There's a risk of burns. Standard end-tidal CO2 is okay because that's just plastic tubing and there's nothing that's incompatible there. Standard blood pressure cuff is okay, but many of the automatic machines are not compatible. So one either has to have very long tubing that runs out to a different, to the automatic monitor. You have to have a different automatic monitor that is compatible. And as we mentioned, the magnet can cause artifacts, especially of ECGs and invasive monitoring waveforms. And in fact, that's why it's a problem with even MRI-compatible pacemakers, because even if the pacemaker doesn't have the ferrous material that's going to have it ripped out of the patient's chest, the pacemakers can be, and ICDs can be inadvertently reprogrammed to do erratic pacing or no pacing or shut off the anti-tachycardia defibrillation functions. So anytime a patient is in the magnet with or MRI with a pacemaker, they need to be monitored by cardiology either before, after, or usually during the entire procedure. So let's do a question. Which of the following interventions is associated with survival in a patient having an anaphylactic reaction to IV contrast agents? A, hydrocortisone, B, diphenhydramine, C, phenylephrine, D, epinephrine, E, dexamethasone. So all of these drugs may be used during an anaphylactic reaction, but which one has specifically been shown to be associated with an improvement or chances of surviving an anaphylactic reaction, and it's epinephrine. So the sooner one gets epinephrine, the more likelihood that patient will survive an episode of anaphylaxis. Allergic reactions under anesthesia are sometimes hard to diagnose because they don't present with all the typical findings. In fact, it's actually quite rare for one to see a rash. Often one is just sees bronchospasm, hypotension, tachycardia, and those things, of course, can be associated with non-allergic, non-anaphylactoid causes. So one should keep an open mind about allergic reactions and be well prepared to treat them. So there's different interventional procedures. We were talking a little bit about diagnostic and about this, CT scan, MRI, angiography, but then sometimes procedures are done for therapeutic reasons. And again, we are increasingly being asked to provide services for those because these therapeutic interventions are increasingly more detailed, complicated, and often are combined with certain surgical procedures. So one of the most common is percutaneous transluminal angioplasty. This can be with or without stenting. Angioplasty just means some kind of opening of a blood vessel. So that can be venous, arterial, it can be in the brain, it can be in the kidneys, it can be in the heart. Radiologists, interventional radiologists can access these vessels from a variety of positions, the internal jugular, the axillary, the brachial, the femoral. So again, just like you need to ask, what kind of position the patient's going to be in, it's important to ask exactly where they're going to be approaching these vessels, and that will determine where you're going to be located and where your machines are going to be located and everything. So sometimes the therapy is to deliver thrombolytic therapy or to open up a clotted vessel. So this is given to open up occluded vessels. Increasingly, these are being used in stroke treatment of strokes. So they're trying to advertise, like a heart attack, a stroke attack. And there's this need for quick intervention to restore blood flow to prevent damage to the brain. So increasingly, we may be asked to help out with these kinds of cases, and sometimes it's in the middle of the case actually being done, where you need to come in and be part of the team. The other thing that sometimes one is doing is actually stopping bleeding vessels. So the opposite. So you'll be embolizing something. And this is usually done in situations where patients have AV malformations or aneurysms or some sort of traumatic injury from either, trauma or surgical injury where they need to do interventional procedures to stop bleeding. You maybe find yourself in the cath lab, the cardiac cath lab, work with a cardiologist. You may be in interventional radiology with a radiologist. You may be in a regular operating room with vascular surgeons doing these kinds of procedures, or you may be in what's called a hybrid operating room, where it's a combination typically of radiological or interventional services along with your typical surgery. So the cardiologist with the cardiac surgeons doing valve procedures, or the neurosurgeons with the neuroradiologist doing something. And some of these providers are more or less familiar with what we do as with anesthesia. So specifically for neuroradiology, I mentioned how that increasingly these thrombolytic therapies and embolic therapies are being used to either open up occluded vessels or to stop bleeding vessels to prevent strokes. And they often are done as emergency procedures. And sometimes the patient is young and healthy and has an isolated, AVM or subarachnoid hemorrhage, and sometimes they're very elderly and ill with a lot of medical problems. It may be either a diagnostic procedure to find out what is bleeding or what the problem is, but usually it's combined with a combination of diagnostic and therapeutic. The interventions may be either drugs that are delivered locally through catheters, or even actual devices where they use coiling mechanisms to create a thrombotic surface to close off a bleeding vessel. One of the most important things, I can't say this enough, and I've said this several times already about immobility, but it's having patients be completely and totally still. So that if they, for example, do a diagnostic angiogram and now they're going back up there to try to employ or deploy a stent or they're trying to deliver some thrombolytic therapy. They want to make sure they're in the exact same location, and so they're often comparing all of these pictures, up on the screen with live fluoroscopy, and the patient moving even the slightest amount may end up being the difference between them, successfully treating some lesion without causing other harm because they're in exactly the place they need to be, as opposed to, deploying the stent in the wrong place. It's also important that sometimes the hemodynamic management of these patients are very, very important. And you don't often know that, again, unless you discuss that with the interventionalist ahead of time and find out exactly what to expect. Is there going to be hypertension in the situation? Is the patient at risk for hypotension? What are the parameters that you want me to keep the blood pressure in? When can I expect to see the hypertension, or when can I expect to see the hypotension? Because, all of it is often about anticipation and prevention rather than waiting until something happens. And it's important to, maintain adequate blood pressure to maintain adequate perfusion, but obviously to also not have excessive blood pressures to prevent rupture or bleeding. You don't usually need, or frequently you will not need your own separate A-line. And in fact, taking time to establish A-line or something like that may be the difference between getting the patient, quickly into the procedure and having the therapy begin, as opposed to, a delay, because you can often just use their vascular sheaths, because they may be going into the femoral artery or into an artery brachial, and then you can just toggle off the side of that. So just ask. You may need to help manage the anticoagulation. Sometimes they will ask you to give intravenous heparin separately or they will be using these drugs on the field. And in fact, you may not even know they're using it until you're quickly asked to give protamine to reverse heparin that you did not even give to begin with, because they gave it, because now the patient suddenly is bleeding and they're not so worried about thrombosis, but now they're worried about the bleeding. Excuse me. And it's also important that one generally sort of plan to have a smooth and rapid emergence from anesthesia or sedation if this is anticipated to be the case at the end of the case, or even during the middle of the procedure, because they may want to have a patient that they can wake up and do neurologic checks on. Some special things about thermolytic therapy, because some of these agents that they're using are enzymes that will convert, like, for example, plasminogen to plasma, which is a natural thrombolytic that then breaks down fibrin and fibrinogen in the clot. And so the patient can be allergic to these drugs. Usually they are going to be infusing the agent at a specific rate for a specific duration. Often, in fact, very commonly, you're going to be either administering heparin or they will be administering heparin. They may need you to monitor that heparin. Sometimes they will be doing it with their team, monitoring ACT and just reporting back to you, but sometimes they expect you to be able to do it. And as I mentioned, you may need to quickly be able to reverse with protamine. The intraarterial agents that they may be using different intraarterial agents to treat or prevent vasospasm, particularly during the cerebral interventions, particularly for something like a subarachnoid hemorrhage or an AVM. They may be giving it directly through their catheters. They may ask you to give it. So, again, if you're not regularly familiar with these kind of cases, knowing ahead of time what they expect or anticipate will be very, very useful. Verapamil, nicardipine, and nimodipine are commonly used. These are all calcium channel blockers. They're very specifically effective in treating vasospasm. And so if you do see hypotension secondary to these agents, it may be hypotension that's refractory to your usual kinds of vasoactive substances such as phenylephrine, ephedrine, or even epinephrine. But IV calcium is a direct antidote, essentially, and is the drug of choice in refractory hypotension caused by calcium channel blockers. So even if the patient hadn't gotten it while you're with them, remember they may have gotten it before while they're in the ICU or in the ER, particularly nimodipine, because it's only an oral agent. So some of the indications for embolic procedures are, anytime you have some kind of a bleeding someplace. So you can have bleeding anywhere there's blood vessels, and you pretty much have blood vessels everywhere in your body. So GI hemorrhages commonly vascular anomalies in the liver, the kidneys, the brain, the lungs even, embolizing uterine arteries for the treatment of either fibroids or post-delivery hemorrhage. Aneurysms, again, aneurysms anywhere there's arterial blood vessels. Cancer treatment. They may be delivering either chemotherapeutic drugs or other kinds of embolic therapies, either for the treatment of the cancer itself or prior to an operative procedure where they want to try to decrease the blood flow to some tumor so that there's less bleeding during the actual surgical resection. Complications of these treatments can include dissection of various vessels, a stroke, ischemia, obviously contrast reaction or allergic reactions. Agents that are used either permanently or temporarily include drugs and compounds and devices. So glue, silk thread, alcohols, coils, gel foam, autologous blood have all been used. They all have sort of different implications, whether they can cause local complications, toxicity, or whether one can absorb them systemically, such as the alcohols, and cause a problem. Or whether they, if they do get dislodged or go to the wrong place, the implications of that. Again, you may be giving heparin and reversing with protamine and having to monitor with ACT. So here's an 88-year-old with Parkinson's disease who presented to the emergency room with a right-sided weakness. The neuroradiologist wants to evaluate the patient in the IR suite for thrombolytic therapy for presumed stroke. Which drug is contraindicated? A, protamine, B, heparin, C, metoclopramide, D, nitroprusside, or E, propofol. What drug would you not want to give? And it's metoclopramide, because metoclopramide is contraindicated in patients with Parkinson's disease because it's an anti-dopaminergic agent, and it can exacerbate symptoms of Parkinsonianism. So even if you were concerned that the patient had just eaten, was a full stomach, needed to have a general anesthetic, I would not recommend the use of the prokinetic metoclopramide in this setting. So GU procedures, the reason I'm mentioning them is just because they are typically done in a prone or not supine position, because generally these are done for lesions in the kidney, either bleeding, tumors, or biopsies, or kidney stones. And so usually the patients are turned prone and you will have limited access to the airway. Usually minimal sedation to deep sedation and local anesthesia is going to be adequate unless it's a particularly large tumor or something where they're going to be perhaps ablating it or delivering certain chemotherapeutic agents that may be much more painful. Speaking of that, cancer therapy is one of the more common therapeutic reasons to have us involved in the treatment of these patients in the radiology suite. But again, for most radiology procedures, whether they're diagnostic or therapeutic, the radiologists are used to doing their own sedation and monitoring or having, directing a team of nurses to do that. So generally, the only time we are called or we get involved is when there's issues. It's either a very, very sick patient, a patient with a difficult airway, or a very lengthy, difficult, anticipated procedure, or in the middle of it when things aren't going so well. So again, by the sheer nature of it, when you are called there, one of the first things you should ask is, why do you need me? Like, why am I being asked to be here? How is this different than your usual routine run-of-the-mill case that you do this way? So for, these cancer therapies can be delivered, almost in any organ, but most commonly it's liver, kidney, lungs, and adrenal glands. And often they're patients who are considered non-operative candidates, either because they're too ill or because of the location of the tumor or disease is not amenable to surgical resection. So a term is TACE, which is transarterial chemoembolization. It's given usually percutaneously, either by accessing a vein or artery and threading catheters up through there, or sometimes directly percutaneously, through the abdominal wall into the kidney or the liver. They may be using laser, cryoablation, alcohol, radiofrequency waves for ablation. They usually are imaging If it's ultrasound, you can be in the room at all times. If it's CT or MRI, it may be a process of, going in and out of the room, imaging, leaving, coming back. And so again, during the imaging and just diagnostic pieces, there may be very little need for much anesthesia. But then during the treatment part, which can be highly stimulating, there may be the need for a much greater depth of anesthesia. Sometimes MAC is fine. Sometimes GA is necessary. Again, ask. So radiation therapy is, external beam, or again, can be delivered via a variety of different mechanisms. Most of the time, we are not needed to have patients hold still for radiation therapy. This is most commonly used for children, or most commonly used for patients who are developmentally delayed or uncooperative and can't. They're usually very short. They're usually every day, sometimes even twice a day, for several weeks. The patients typically when they finish with this, they have no sort of residual pain or discomfort. And so many patients will come in before they go to work, or they'll come in after work, or they'll even come in on their lunch hour to have these therapies. Or parents are bringing children in right before they're going to work or something. And so they need to really prefer the patient to be up and about very quickly. So most of the time sedation is all you need, but sometimes you would need a general anesthetic depending on, again, the situation, particularly with airways favorable. But you want to focus on fast onset, short-acting drugs with minimal side effects. Usually drugs like propofol and dexmedetomidine are ideal. There really isn't any pain or discomfort generally, unless the patient, of course, has some other pain, or like if the vertebral tumors are causing vertebral fractures and pain to lie on their back. And the ablation therapies, in contrast, though, can be very painful. Sometimes it's just very transiently painful, but very painful. Or they can also be very stimulating with marked tachycardia and activation of the sympathetic nervous system and hypertension. And even arrhythmias. So again, depending on the situation, if you've got a patient with ischemic disease, you may need to anticipate blunting that. These are not dissimilar, I think, to like ECT, what we were talking about earlier with ECT, where there's an intense stimulus that results in hemodynamic perturbations. And sometimes they're always or almost always self-limiting. Sometimes there's no need to treat them or prevent them, but in other situations, there may be a definite reason to intervene. Make sure if they're ablating using alcohol, that you watch for signs of alcohol toxicity. This is usually results from inadvertently being delivered intravascular, or from very large volumes or extravasation outside of the intended target. The patient will often cough or have a choking sensation, develop tachycardia. They may have respiratory depression, sedation, and even seizures. So, particularly for vascular procedures, you may be doing this in a vascular OR with a vascular surgeon, or with an interventional radiologist, or a cardiologist, or even a surgeon, or a cardiac surgeon. They may be just simply diagnostic, where they're just administering dye or contrast and taking pictures. But again, the immobility part is very key, and making sure the patients hold still. Or they may be doing something therapeutic, which is angioplasty, or using balloons to open up occluded vessels, or placing stenting devices. IVC filters are a type of vascular procedure. If you do them with vascular surgeons, they usually do them in operating rooms, and they access the IJ to place their IVC filters. If you do them in the radiology suite, it's usually the radiologists access the femoral. I don't know why they sort of have different approaches, but they typically do. It's really just a percutaneous stick like you would for a central line, and then threading the catheter and deploying this. So generally, we are not there, and we don't need to provide anesthesia, but if you're asked to, it may be, again, because of a special circumstance. Usually these procedures are all done in a supine position. If you're down the IR suite, the access is almost always through the femoral vessels. Again, ask if you can use their sheath if you need invasive monitoring, rather than taking time or wasting effort to establish separate arterial monitoring. Immobile patient again. And again, for some of these procedures, they want the patient to hold their breath, particularly if they're up under doing work on the liver or the kidneys or in the chest, where the breathing may interfere and move the organ. They may need the patient to hold their breath. So if you have your patient lightly enough, sedated that they're able to still follow commands, then you can just ask the patient to hold their breath. But if for some reason that the patient were requiring a deep sedation, they were not able to follow commands, then in this situation, you are going to need to, do a general anesthetic so that you can have control over the patient's breath holding. So generally for most angiographic procedures, whether diagnostic or therapeutic or both, MAC anesthesia is fine, but lighter MAC is better than deeper MAC. Again, many times we may be there more for the monitoring or in case something awful happens to the patient because they're very, very sick, rather than the need to actually provide anesthesia or drugs. So some patients are given oral contrast to swallow prior to having CTs, particularly abdominal CTs. And so this would increase their risk possibly of aspiration, especially if the patient had other reasons to be worried about delayed gastric emptying. Some oral contrast when it gets into the lungs is very bad. In fact, barium is actually quite benign if one aspirates barium, but some of the more newer contrast agents can cause much more of a significant pneumonitis. So you may need to intubate that patient. IV contrast, patients can be allergic to IV contrast, and IV contrast, all IV contrast, in my understanding, is nephrotoxic. So if the patient is starting out with a decreased GFR, then they can choose less nephrotoxic agents. I don't think there's no nephrotoxic agents. And aggressive hydration may lower that risk. So if the patient can tolerate fluid for other reasons, this is the time to hydrate the patient. Contrast reactions can be anything from sort of annoyance and sort of side effects like itching or feeling kind of warm or hot all over, to true full-blown allergic reactions and anaphylaxis. So some of the common symptoms are, can be vomiting, a rash. Hives is generally indicative of a true allergic reaction. Hypotension, laryngeal edema, wheezing, bronchospasm, dyspnea, cardiac arrest have all been associated with IV contrast. Patients who have had previous IV contrast reactions are more likely to have future and worse reactions. Each allergic reaction tends to get worse. And patients who have asthma may be atopic individuals that have increased reactions, and patients who have multiple allergies, especially if they're true multiple allergies, not just like side effects like nausea and vomiting to opioids, but truly they've had hives and anaphylaxis to other agents, they're more likely to also react. So if you've got patients who are felt to have just, side effects or minor allergic reactions, they can have prophylaxis, which can consist of all of these: prednisone, H1, H2 blockers, or one or more of those. Usually H1, H2 blockers are part of pre-treatment always, and then the dose and amount of prednisone depends on how significant the reaction had been in the past. You should know ACLS and hope the other people around you know CLS, and obviously it's all about airway, breathing, circulation, but administer fluids. Benadryl will help decrease the bronchospasm and decrease some of the other side effects, but it has not been associated with improving mortality in the setting of true anaphylaxis. So that's where the epinephrine comes in. If the patient is truly having a full-blown anaphylactic reaction or they've already developed hypotension, then you should be giving it to them IV, not subcutaneously. The small doses of epinephrine we're used to giving, 10, 50, 100 mics, generally is not effective to treat anaphylaxis. You need much bigger doses, half to a full milligram. Hydrocortisone is generally important that you give it, but it's not going to immediately have an effect. But what it does is help to the patient to not have sort of a recrudescence of their anaphylaxis or allergic reaction a few hours later when these other shorter acting medications have been eliminated. So it's important that you both protect yourself as well as the patient from radiation. It seems kind of odd to think about protecting the patient, but the patient's down there to have, an imaging of their chest and they're of childbearing age. Then obviously you want to make sure they're not pregnant, and then you want to shield their reproductive organs, shield their thyroid when you can. and you should do the same for yourself. You should wear lead aprons. Make sure that you don't, if you just have the one that covers the front, that you're not turned around all the time and exposing your backside. You should definitely wear the lead thyroid shield. Your thyroid is very sensitive to radiation. I mentioned that this morning when I talked about, endocrinology and about using radiation to treat thyroid disease or patients who had head and neck irradiation for other reasons, having to destroy their thyroid. Radiation also causes cataracts, and so you should be careful about wearing either goggles or standing some distance away or standing behind leaded glass shields. It's amazing the distance. It makes a big difference. Every foot you're further away, you significantly decrease the amount of radiation exposure. So stand as far as you can away. There are OSHA limits of how much radiation one can be exposed to annually. And if you regularly work in radiation areas, you must wear little meters to measure your radiation. I believe every hospital is supposed to offer everybody who's around radiation the option of having a dose meter. So I think you can ask your hospital for that. But if you regularly find yourself in these rooms, I would highly recommend that you wear a dose meter to limit your exposure. Which of the following can occur during magnetic resonance imaging, even if using compatible equipment? A, electrical burns. B, exposure to radiation. C, the risk of missiles from objects being attracted to the magnet. D, damage to cell phones. E, artifacts on invasive monitoring waveforms. So which of these can occur even when you are using MRI-compatible equipment, or making sure that only MRI-compatible equipment is within reach of the magnet? And yes, it's the artifacts on invasive monitoring waveforms. That is something that just, cannot be avoided. And sometimes it's, in fact, your A-lines will be almost useless, and so you will need to rely on non-invasive monitoring or pulse oximetry. There is no exposure to radiation in an MRI, but all of those other things, can occur, but only if it's you're using the incompatible equipment. So just a couple slides on pregnancy testing. A 32-year-old woman presents for a laparoscopic cholecystectomy. She is nursing her 8-month-old son. Her last menses was prior to her last pregnancy. Regarding her care, which of the following is most appropriate? A, the patient should be offered a urine pregnancy test. B, the procedure should not be performed under general anesthesia. C, opioids should be avoided since she is currently nursing her child. D, it is mandatory that the patient have a serum pregnancy test before proceeding to the OR. So which of those is the correct response regarding this patient? And yes, the ASA is quite specific in saying that women should be offered a pregnancy test, but that they should also be offered or be allowed to decline that if they so desire, and you should not refuse to offer them care as long as you explain the potential risks or complications of anesthesia and the procedure on a pregnancy. So these are recommendations that any woman of childbearing age, and that includes menstruating females up until 1 year after the reported menses. One is not deemed menopausal until you've had at least 1 full year without having a period. That these are offered to women regardless of the history. We know that history is actually very poor in determining whether a woman is likely to be pregnant or not, with the exception is if she doesn't have a uterus to carry a child, or if she doesn't have ovaries to produce eggs, then I think the history is sufficient. It's probably best to test on the day of surgery, actually, because even testing a few days before could result in a woman having her pregnancy test turn positive in that interim. A urine test is sufficient. The modern urine tests is almost essentially as specific and positive as early of a pregnancy date as the blood tests. For all patients, there should be documented consent from the patient or the guardian that they've agreed to undergo testing. And for all patients, it's important that you document a detailed menstrual history, because no test is perfect. No test is absolutely 100% accurate. So if a patient, has a menstrual history that's compatible with pregnancy, and even perhaps believes that there's a possibility they could be pregnant, one should at least consider doing a, 2 pregnancy tests before deeming that that pregnant patient is not pregnant. Thank you very much for your time.